With all the news about valley fever in Washington state and the recent soil testing, I spoke with Dr. Tom Chiller from the CDC about recent developments and the road ahead. To start all this, would probably be a good idea for a recap of what's going on. That in 2010 and 2011, there were the three patients in Washington state who had been infected with valley fever. Their cases had been studied, and in all of those, even though it was suspected that it could have been caused as a result of infection within Washington state, that they could have also gotten this from previous infection elsewhere, perhaps years earlier, that might have reactivated. But the really big news came during the soil testing, where specifically the soil in Benton County was found to have Coccidioides in it. Tell us how that happened, because it's my understanding that the soil sampling happened at the time of those cases, but it wasn't tested until much later. What happened with that?
Yeah, no, thanks. Thanks for that, and thanks for the background, David. We have always been, concerned that the traditional geographic or so-called endemic areas for valley fever, were probably not accurate. I mean, these were done, as you know, using skin test results in the 50s from Navy military recruits, and then we mapped out based on those skin test results where we thought the endemic areas were. And clearly these are still endemic areas today, but that was over 50, 60 years ago now. And we know things have changed, and we know that there are rodent populations on the move. We know that climate change has come into effect, and there are droughts and there are rainy seasons. And so we always wondered, are the traditional geographic or endemic areas still valid today, or is there cocci or valley fever in other parts of the U.S.? So when we got the notification of these cases in Washington state, we began working with the state and the local health authorities to investigate them and to understand whether or not there could have been local acquisition. At the time, as you mentioned, there was certainly a lot of circumstantial evidence suggesting that these could have been locally acquired. But as you also said, everyone had a travel history. And as we all know with valley fever, all it takes is one trip to an endemic area to potentially be exposed and become infected. And so we wondered whether or not these patients could have actually had reactivation disease, even though we thought, and we talk about this in the paper, we really thought that this was more than likely locally acquired. So at the time when we were doing the investigation with the state and with the local health authorities, we decided that we would go back and we would get soil samples from the area where the patients were. And at the time, we really didn't have a good way to find cocci or coccidioides in soil. So we thought, all right, let's go out, let's collect samples from around where these patients might have been exposed, and let's go ahead and store them with the idea that we would look for laboratories or other researchers that were doing work with environmental samples. And then CDC itself wanted to begin a program to be able to see if we could identify valley fever in the soil or in the environment. Subsequently, as you just mentioned, we were able to develop with help from the company Translational Genomics, TGen, based in Arizona. We were able to develop some DNA testing so that we were able to then take those soil samples out of storage, go back and actually find coccidioides, as well as improve upon some methods for culturing the actual organism out of the soil. And indeed, we found cocci in the soil where the patients were exposed, and furthermore, we're then able to take isolates from one of the patients and match them with one of the isolates from the soil genetically by doing genomic sequencing. So looking essentially at the DNA patterns and finding that these two isolates matched almost identically. And with all that evidence now, we really did feel that this was a local acquisition, and that coccidioides was indeed found in that area. And then that really got us starting to talk with the local authorities as well as people within the field to begin to think about how we might investigate where else valley fever could be found.
For the testing, was this just in Benton County, or was this in the other two areas where in Franklin County and Walla Walla County where the other ones had been exposed, or at least where they had resided?
Yeah, thanks for that. No, it was just in Benton County where we were able to get the soil samples from. Um, that is where we were able to collect them at this given time. I think that now, as we are moving forward and thinking about a sampling strategy for the environment in the future, we will be looking into sampling in other counties and where some of the other patients might have been exposed. I think we also want to think about, as you well know, and as many people know about valley fever, it is a big problem in domestic animals, especially dogs, who are sniffing soil and are exposed to soil. So we also want now to begin to look in the veterinary populations and maybe work with some of the veterinary groups to find out if dogs have been exposed or if there are infections in dogs. And it could be then that we could develop some sampling strategies for the environment based on where we're finding other infections. For the time being, it is still very rare. I mean, we still only have these 3 cases, and we haven't had another case reported since 2010-11. So now our efforts are going to go into actually developing a strategy for looking for how we're going to define the newer areas where geographically valley fever might be found.
One of the things I found that was interesting about this is that the species found from it is C. immitis, and which is often regarded as the Californian valley fever because the Possidacea strain is generally found in Arizona and elsewhere. Is there any significance to the fact that this one in Washington State is actually from California, which does not seem to have been spread as much geographically?
I think it's a great question. I mean, to me, again, postulating and thinking through this a bit, I mean, we would think that the cocci that was found on the coast there, up the western coast in Washington, would be similar to the other Coccidioides species that are in California. So it makes sense to me that immitis would be the predominant species, and it makes sense to me for 2 reasons. One is, if it's spreading up north or down south, however it's spreading, we think of 2 ways that this could be happening. One would be, environmentally, through wind, through getting stuck on tires of cars, soil, etc. Ways in which soil or dust are being blown or moved up north. The other way, though, which I think is also a very intriguing hypothesis, is the fact that we think that it may be related to desert rodents. And cocci has been found in desert rodents. There are several theories about it being potentially a zoonotic organism, meaning that it lives in an animal, and then when that animal dies, then those spores are spread into the environment. And that indeed has been found in some cases. So one also then wonders, is it a migration of a rodent that has taken it up north? And that would again say that that either the rodent is moving because environments are changing, or they're being pushed out of their current environments due to development and growth. So I think there's a lot of possible explanations, but to me it does make sense that immitis would be the species if it was moving up north.
And it's interesting you mentioned the zoonotic aspect of this because I believe it was back in the 50s, the really old-time cocci researcher Charles E. Smith had done some research where some animals that had died of valley fever had been buried, and he was able to recover C. immitis from the soil where they had died. So there hasn't been a lot of study on that. Do you see that as a expanding area of interest for the CDC and perhaps other research?
I do. I do think we need to be thinking about this as we're now, contemplating and wondering about where valley fever is, where the fungal spores exist, and how they're moving. I think we need to go back and revisit the the zoonotic hypothesis. And I think there are some people, as I've already mentioned, that do feel pretty strongly that cocci can have a zoonotic origin and could be spread, via the zoonotic route. So yes, I think we need to look into that. I think we need to understand it more. It can be challenging, but I think as we're thinking about how this organism might be spreading, certainly if we thought that the zoonotic spread was the primary way in which it was moving to different geographic areas, then understanding those rodent movements would be key to understanding where it's going.
Absolutely. And another thing that we've been wondering about with the recent DNA test that has been able to be used in this, how soon is it likely that could be used in other circumstances? Because there are so many people purely wondering from how they were infected, should I have my gardens tested? The whole idea of gardening, sometimes in the San Joaquin Valley or Arizona or some of the other areas, has been known as a risk factor. How soon do you think it would be possible that this kind of technology might be brought to market?
Yeah, I mean, I think that's a great question, and I can understand the public, wondering and being concerned and wondering whether or not this could be something that could be useful, in their own endeavors to understand if spores or valley fever spores are present. I mean, I think we always, when we're dealing with a new technology like this, we need to take it with, a certain amount of caution. We don't want to overinterpret results. We want to make sure that we're really comfortable with a positive and a negative result. I'm often concerned that people overinterpret the negatives, and we're really early in understanding how well this test performs. So to me, even going and not finding cocci doesn't mean it's not there. And so I wouldn't want to give someone really the false sense of security that there wasn't any cocci present just because we did an environmental test. As you know, it's sort of like a needle in a haystack to a certain extent. We're sampling one little bit of soil, and yet there's soil as far as the eye can see that isn't being able to be sampled. So I do think we need to think strategically, that we need to work out more of the details of the test. It's very new for us. We're excited that it works. We're excited to be able to use it like we were able to use it in Washington, where we really were looking for something specific. I think just applying it more general is going to take some time, and it's going to take some more understanding about the utility, about how well the test is performing, etc. But we're certainly engaged in doing that, and we want to learn more about the test and understand where else it can be applied and how else it can be used.
That makes a lot of sense, and it's also good to be thinking of that in terms of safety and understanding that negative tests are not going to rule it out. Sometimes a lot of patients with valley fever have to communicate that to doctors who are sometimes overzealous in thinking a negative test equals, in a patient, that a negative test would equal no infection, when sometimes anergy is set in or other things. And I believe it was Dr. Egerberg in the 1980s symposium who wrote that he was using the soil testing of the time, and he was never able to recover a sample, even though he was sickened and infected while trying to gather a sample. So
No,
that,
and as you know, absolutely in the fungal world, and where we are engaged, and as myself at the CDC, being one of the people who works hard on fungus and fungal diseases, 24/7 for the public, we're challenged by these things all the time, and diagnosis, false negative tests, false positive tests, unfortunately in the fungal world are quite common. And so you're right, we need to be thinking about the bigger picture always. We need to take lots of things into consideration. And I think you bring up something that CDC feels very strongly about, and that is clinical awareness and education. And it's something that we really want to work hard on with states, with clinical societies, with local health departments, and that is to at least make clinicians aware about this disease. Certainly in Washington now, there's going to be efforts made so that clinicians are aware, so they can work on diagnosing the disease, so they can get consultation from experts as needed. We need to be aware, and we need to be thinking about it, because if we're not aware and thinking about it, then we're not diagnosing it. And certainly then there comes with that the whole challenge of diagnosing it and dealing with false negative and tests, etc. But I want to start at least with making people aware that the disease exists and that they need to be thinking about it.
One of the things I'm wondering about when you're contacting local health departments, also local veterinarians, as you said before, because that's another important aspect, is how do you decide what the most important information is to distribute to these local organizations?
Yeah, well, I think the first step is just general awareness about the clinical disease, about what tests are available to diagnose it, what are the best ways to manage it and treat it, and then how to make sure that it gets reported to the correct local and state authorities, so that we can hopefully keep track a bit and understand where it might be present, and in what populations and areas it exists. And so we focus really on those four aspects initially. Certainly, as we develop more knowledge about where it exists and about whether people are finding it, we can get into more depth into, for example, environmental sampling and strategies to look for it in the environment. Prevention strategies, and warning people about where it might be and how they can potentially avoid, at least in times where there are dust storms, etc. As you know, we all breathe, and unfortunately, we can't protect oneself from breathing. We need to breathe, and so if you are in an area where the spores exist, you're going to be exposed. And so really our job is to make people aware, so that if they do have symptoms, that they ask their doctor about it, and then obviously try to provide some basic prevention strategies as they can be provided. And certainly for patients that are at high risk, like those patients with immunosuppressed conditions, so that they are aware where the disease exists geographically. And again, I think the best thing we can do for people is let them know, ask your doctor about this disease if you have a symptom.
One of the things I've been wondering about with these particular Washington state cases is, has there been follow-up with the patients themselves that the CDC has done? I know that, of course, they have their own doctors and that it's not necessarily directly connected to the CDC reporting. But do you have additional information on them?
CDC, we are really there at the behest of the state and the local health department. So it's the local health department that does all the follow-up on the individual patients. We've been providing consultation and advice and really a lot of technical guidance, but it's the locals who deal with the patients every day. I know that they did quite a bit of follow-up initially. I'm not sure what has happened. Obviously, it was several years ago now, so I'm not sure whether there's more follow-up now. I think really the local and the state authorities are now focusing on the issue of awareness and sort of trying to understand the best strategy to move forward in thinking through how to characterize the geographic issue with cocci in their state.
How is the CDC going to be moving forward insofar as testing for the expanded area? For example, even I heard that Umatilla, Oregon might be an area that would be considered. Is there going to be additional soil testing that will be taking place?
Yeah, I think that's a great question. We are actively working on strategies to be able to sample environments and understand where the spores might be. And it's as you can imagine, these are gigantic, vast geographic areas. And again, it's a little bit like a needle in a haystack. The advantage of the Washington situation is we knew where these patients were exposed, or at least we thought we knew, at least we had pretty good ideas. So we were able to go there and sample in a pretty defined geographic area in a small space. In other areas like Oregon and which clearly is in the path one would assume of C immitis if it's moving up from California, one would want to develop a sampling strategy and an environmental sampling strategy for Oregon. So we're thinking hard about how to do that. And certainly I'm concerned that if we if we do it in a non-thoughtful way, again, we might be dealing with a lot of negative tests. That doesn't necessarily mean it's not there. So I think we just need to be cautious how we interpret what we're doing, and we're certainly going to work with Oregon State, the health department, as well as the local health departments in Oregon, and probably several other states as well, to begin to assess the environment. But we'd like to also, again, do it in a similar fashion as in Washington, and that is, engage the veterinary community so we can find out whether we can improve some diagnostics and get some more diagnostic tests done on animals, certainly dogs, and then also humans. When people come in complaining of a cough or a cold, certainly something that doesn't go away, doesn't go away in a number of days. Having providers think about Cocci and maybe running some of the Cocci diagnostic tests, that's another way to help us hone in on where an environmental sampling strategy might be best undertaken.
Do you know if the new spherosol test that had just been approved this year, if that would be a part of the CDC strategy coming up?
Absolutely. We are very excited about spherosol, the skin test antigen being available and approved. We are very interested in using that to help understand those who have been exposed. As you know, the same antigen with a very minor difference in its formulation, or in one of the chemicals that's used in its formulation now, was what we used in the 1950s to define the geographic or endemic areas for Cocci. And so having that available again, I think it opens up some exciting possibilities for being able to use the skin test to maybe help us evaluate risk. So what we're hoping to be able to do with the skin test is to be able to use a positive skin test to tell us that someone has been exposed, and if they've been exposed, they are more likely immune, which we think a skin test result of a positive skin test result would make that person more likely immune and not at risk for further disease. That's not a perfect test for that, but we're excited to evaluate it for that use, because if we could use the skin test to be able to look at those who are exposed and essentially immune versus those who have maybe been exposed but are not immune yet, we might be able to help classify people who are at risk, certainly for risky occupations or being put in risky environments. And that's very exciting. Again, very new. We haven't developed those strategies yet. We've been thinking about it for a long time, and we are very excited to incorporate the skin test into strategies moving forward.
One of the things I've been wondering about that, is there a schedule for the kinds of things that will be tested and going up ahead for the CDC to expand more in the epidemiology? And also about the monetary cost for these kinds of things, because that is almost always the number one obstacle in just about anything with valley fever.
No, and you're absolutely right. Funding has been a big obstacle for valley fever and for many years. And again, my own personal issues with valley fever go way back to my days at Stanford University as an infectious disease fellow, where I took care of a lot of really sick patients with valley fever, a lot of the patients with meningitis, which as we all know is one of the more devastating consequences of disseminated disease. And it certainly touched me dealing with patients that some of which unfortunately succumbed to the disease, and made me a big proponent of trying to do something. And so you're right, funding has been a challenge. I think we've managed to get a little bit of extra funds this year to work on some of the epidemiology, and work on some of the environmental testing. So we're excited about that. That's what I think is going to allow us to at least begin some of this environmental sampling, and also work with states and local health departments to try some enhanced surveillance in both the veterinary and human communities. But it's a challenge, and I think it's important to raise awareness. And your group and others do a great job of that, and we continue to support this kind of awareness and education around the disease. You asked, the first part of your question was about sort of our strategy moving forward and whether we have a plan. I think we're focusing a little bit right now on Washington and probably Oregon, but what we do want to work with some other states, certainly states that are in the endemic areas like California and Arizona, that already do a lot of valley fever work, but have also had issues with funding and finding funds. I think we're going to be able to help them with a little bit more funding this year, as we did a little bit last year, to really look harder at some of the clinical consequences of the disease, try to characterize the disease better, and again, maybe incorporate some of the skin testing algorithms into some of the ways we look at risk. I think one really exciting aspect of valley fever has been the engagement of Kevin McCarthy in Congress. He's currently the majority whip, and his district is in Bakersfield. And last year we went out with Congressman McCarthy, as well as the CDC director Tom Frieden and the NIH director Francis Collins, to have a valley fever symposium. And I think it really helped kickstart some of the renewed efforts in this disease, and it's great to have Congressman McCarthy, as well as I think he has about 10 or 12 colleagues now that have formed a valley fever task force in Congress. And I think that having that advocacy group in Congress is going to be helpful, and I think we're seeing some of the fruits of that advocacy. One aspect of that is very exciting is our engagement to help NIH, who is leading an effort to work on designing and then implementing a randomized controlled trial where we're going to look for the first time at primary therapy for coccidioides. So in other words, primary valley fever. So as you know, most people that get infected with valley fever are thankfully asymptomatic. We think it's somewhere around 60%. But for the other 40% who develop symptoms, most of those people develop symptoms that are flu-like and can develop a pneumonia. And oftentimes those symptoms resolve, but they may take weeks to months. And we know that this takes people out of work, and there's a severe amount of loss of productivity, of feeling weak and fatigued. And of course, then there are a handful of those that go on to develop more severe disease, of which, again, I took care of many of those patients, and you know many of those patients as well. For those that are in that first phase, that primary phase, we've always wondered out loud whether getting an antifungal on board and treating them rapidly would help not only reduce and lessen their symptoms, but perhaps even prevent them from going on to develop these devastating complications that happen in some individuals. So we're really excited to support NIH in their efforts to develop this randomized controlled trial and to carry that out, in the coming years. And so again, that's one really exciting effort that's going to be that's going to be undertaken in the coming years with NIH.
And it is nice to be able to get so many of the questions that people have to finally try to get some answers for them. And then there are so many people also who have things like cases where they appeared to be fine earlier on and reactivated. And there's so many other questions that you really do want to have answered, because sometimes you wonder, is it truly that 40% that's so often cited from the old military studies? Could things actually be worse if you follow people over a longer period of time? And
no, and
anecdotally, from so many valley fever people we spoke to at Valley Fever Survivor, you really start to question whether some of the older data is true, or maybe there have been environmental changes or even dietary changes over the populace over the time with different pesticides, chemicals, how many other factors there are.
No, I think you bring up some great points, and I think all of us in the valley fever medical community have certainly questioned those numbers through the years. They are quoted a lot. I mean, I worry being at CDC about quoting old numbers that I don't feel like I've helped generate, or that my colleagues have helped generate. And so it is something that we do want to look at as we move forward in doing a lot of this enhanced surveillance. I think, working on the randomized controlled trial and looking at the populations that we want to study is going to allow us at CDC to actually follow those populations a bit more intensively. And we are trying to collect some of that data. And I agree with you, it would be interesting to reassess that 60-40%. That number is quoted quite a bit. I think all that kind of information is important to constantly question and constantly look at. Things do change, pathogens change, the environments change, and obviously the population changes, which I think is probably what we're seeing most of all in medicine in general. As you know, we're dealing with a lot more immunosuppressed people, a lot more organ transplants, a lot more stem cell transplants. I think we're doing 60,000 some organ and stem cell transplants a year now in the United States, and these people are living a long time on immunosuppression. So I do think populations at risk are also changing quite a bit, and so it's going to be important to look at all these things as we think about valley fever as well as other diseases.
As a final question about some of this, especially because we're thinking about risk groups and how the statistics apply to them, there are some strange contradictions that I found in risk groups, because we know for a fact that groups like African American heritage has led to more severe infections, that diabetes, and of course immunosuppressed that you had mentioned. But also statistically speaking, so many of the people who have been infected tend to be from groups outside the risk groups. So it's sort of a very strange conundrum as to, do you focus on the fact that there are people who are very likely themselves to be suffering the worst that this has to offer? Or do you focus on groups where there are going to be large numbers of people infected, and just simply as a result of the large numbers of these particular groups, they're also likely to have a lot more people in those groups who will be suffering from the worst? How are those kind of decisions resolved for the quality of information so that you have something that, I know there are committees involved, but I'm curious to hear about the procedure for how that is handled.
David, those are great questions, and those are questions that we struggle with not only for valley fever, as you can imagine, but we struggle with for a lot of different disease entities. There are certainly patients or persons of super high risk for some of these diseases to disseminate and to have devastating consequences. But then, as you point out, there are other populations where we may not be as worried about such severe disease, but we're worried about disease in general and getting a lot of it. And that knocks a big proportion of those people out of the workforce for several months. And as you know, some of the data that we collected in Arizona, looking at patients and looking about how much time they lose from work and how long symptoms last, it's pretty devastating. And all these people recovered, but it really took them out of the workplace, took them out of their daily lives, and really had a lot of morbidity associated with their valley fever disease for weeks to months to close to a year for some individuals. So that is important as well. So how do we develop strategies for what we go after? And those are great questions. I mean, I think we try to look at where we think we can intervene, where we think we can do the most good for the most people. And so from a public health standpoint, we are clearly looking at those big populations, and as well as the immunosuppressed. But valley fever is still somewhat of a conundrum in the sense that, as you mentioned, there are what we would call normal or healthy people that get this disease. And so there must be some genetic risk that we don't understand. And so I do think more work in understanding genetic risk and understanding whether there are ways to quickly test people to see if they might be at higher risk for developing valley fever in general could help us target specific groups. In the meantime, I think we need to continue to study that. I think we need to continue to make people aware of the disease so that they can diagnose it, so they can get treatment from their physicians, because that's really the first step. We need to understand how much disease is out there, and without people asking to be tested, or without us educating people to test and to figure out who actually has the disease, it's going to be hard, and we may be biasing who we think is at higher risk than who we don't think. And so I think that's sort of where we are right now in public health. We're looking to push awareness, to develop clinical awareness and education campaigns, both in the human and veterinary communities, to understand geographically where there might be areas at risk, and then, as you mentioned, ultimately to see if we can help target high-risk populations. And those populations don't necessarily have to be those only that get devastating disease, but just people that might be at higher risk to get disease in general.
There's so many factors that we need to think about with this disease and so many different things to look at. But thank you very much for your time and for having this interview set up with us, Tom.
Well, it's been my pleasure. I appreciate all you guys do, and look forward to speaking to you again.
For more information about valley fever, subscribe to our YouTube channel, friend Valley Fever Survivor on Facebook, and visit valleyfeversurvivor.com.